Preeclampsia can cause death for both mom and baby, including preterm birth, which is delivery before 37 weeks of gestation. Preeclampsia is defined as having an elevated blood pressure on at least 2 occasions, 4 hours apart, developed after 20 weeks of gestation in previously normotensive women. Proteinuria, which is protein in the urine, must also be present. Higher risk of complications will occur if preeclampsia is of early onset and severe. Major challenges in obstetrics today include identification early in pregnancy and interventions to reduce prevalence. Previous studies have found that women who take aspirin in pregnancy are less likely to develop preeclampsia. Low-dose aspirin at 50 to 150 milligrams per day also resulted in a 10% lower incidence of preeclampsia development. Additionally, aspirin taken before 16 weeks of gestation halved rates of preeclampsia development, whereas aspirin taken after 16 weeks of gestation had no significant effect. Benefits of aspirin are also found to be dose-dependent, with a greater reduction of preeclampsia seen with aspirin at 100 milligrams or more per day. Currently, it is recommended that aspirin be given prophylactically at 60 to 80 milligrams per day for women identified as high risk. Additionally, combined screening, so including maternal factors and biomarkers, are shown to be most effective in identifying women who are high risk. The key objective of this multi-center, double-blind, placebo-controlled trial was to test the hypothesis that among women with singleton pregnancies identified at high risk with the combined screening, aspirin at a dose of 150 milligrams per day from 11 to 14 weeks until 36 weeks of gestation would result in the incidence of preeclampsia preterm half that of placebo. The primary outcome measure was delivery with preeclampsia less than 37 weeks of gestation. The main finding was that among women with singleton pregnancies identified at high risk, a dose of aspirin at 150 milligrams per day from 11 to 14 until 36 weeks of gestation did significantly lower the incidence of preterm preeclampsia compared with the placebo. In the sample of 1,620 women, preterm preeclampsia occurred in 1.6% in the aspirin group, shown in red here, and in 4.3% in the placebo group, shown in blue here. The information on both of these graphs are the same, the inset just has a larger y-axis. There were no significant differences observed between aspirin and placebo groups in regard to demographic characteristics, maternal history, or the occurrence of adverse events. Additionally, this trial did not reduce the risk of term preeclampsia. Overall, the authors recommend the administration of aspirin at 150 milligrams per day from 11 to 14 until 36 weeks gestation in women who are identified at high risk for preterm preeclampsia. Lastly, the funding agencies and aspirin and placebo distributor had no role in the trial design or the research process.